Good afternoon, everyone. It's 12:04, so we're going to go ahead and get started. My name is Maureen Law. Dr. Tran, our course director, was unable to join us, but he sends his regards. We are super happy today to have Dr. Omotola Hope join us for Neuroscience Grand Rounds. Dr. Hope has no conflicts of interest to disclose. She is a board-certified neurologist. She joined Houston Methodist Neurology Associates this summer. We're super excited to have her with us. Dr. Hope specializes in the treatment of epilepsy. Her clinical interests include acquired epilepsy, assessment after a parent first seizure, diagnosis and treatment of epilepsy, headaches, migraines, epilepsy in women, among many other interests. She is a graduate of the University of Pennsylvania School of Medicine in Philadelphia. She received her Master of Health Science from Yale. She did her internal medicine residency at North Shore University Hospital in New York, and she has completed her neurology residency and an epilepsy fellowship at Yale New Haven Hospital in New Haven, Connecticut. Like I said, she has no conflicts of interest, and we're being recorded today. So if anyone wants to get the recording later, just let me know. CME credit has been approved. The code is in the chat box. It'll also come up during this presentation in Dr. Hope's slides. We've also applied for credit through Texas Physical Therapy Association for all of our PT and PTA colleagues. And so if you can just fill out the evaluation form, your director has it, or I can send it to you as well. And then as soon as that is approved, we will send you your completion certificate. And so I, again, am very happy to present Dr. Omotola Hope.
Great. Welcome, everyone. It's been great settling in so far. But as I'm doing this virtually and I don't get a chance to meet you, I want to see if I can find out a little bit more about you guys. So with that in mind, let's see if I can get some questions going. So I don't know if you guys have used this before, but it's basically a way to ask questions while you're giving a talk. It's called Poll Everywhere. So two different ways of doing it. You can get on your phone and actually download the app, or you can text 22333. So actually two twos and 3 threes, and then put in that Omotola Hope 264 number there. That will essentially send you a link to the questionnaire. And then basically, the first question is, what's your location during the lecture right now? And these are the options: hospital, office, home, or other. And so I'm going to give you guys a couple of minutes to see if you can follow those instructions. So text 22333, and then you put in the text box that Omotola Hope in uppercase 264. And that sends you a link to the essentially to the questionnaire. You don't have to put in any. They might ask you to put in some information about yourself. You don't have to do that. You can just sort of skip that part. So. Okay, we're getting some responses in, so at least some people are doing this. All right, so if we can get up to 20 people, do we have 20 people participating today? I've got 10 responses so far. 11, a few more. 12. Okay, so I'm gonna go. So let's see what the responses were. So we have 50-50. Half of you are in the hospital and half of you in your offices, and nobody's at home, and no one's, I guess, on a strange location on vacation or anything like that. Okay, so let's go to the other question. So here is, again, I'm learning more about you guys. So where are you, where are you primarily? Where's your work? So are you a clinician in the hospital? And clinician covers everybody: nurses, MAs, nurse practitioners, docs. Are you in the office? Are you other hospital staff? You staff in the clinic, or none of the above? So we have 13 responses. 30 more seconds. Did we get 20 on this one?
There are almost 50 people on the call, so some of them are just being a little shy.
Come on, come on. All right, let's keep going. So in here we have 56% of people are clinicians in the hospital. There are a quarter or so that are clinicians in the office, and then you have other hospital staff. Thanks, everybody. That's great. Thank you. And then this is primarily for people that are in the hospital. So where do you work in the hospital? Are you in the emergency department, on the floor in the ICU, or do you do a little bit of, are you working in all the different places in the hospital? So we have 11 responses. Come on, everybody. Okay, if you haven't gotten the chance to log in yet to the poll, you still have the last question. Well, there's a couple other questions, but this one is the first sort of set of icebreaker questions. There's one more coming up, so you can certainly take the chance to do that now. You can go to your phone and text 22333, and then put in that code on the top, Omotola Hope 264, and that will send you a link. And so you'll have a chance to answer the last question and the icebreaker coming up. Okay, so we have 17 responses, and for people in the hospital, wow, most people are kind of working in a lot of different places, maybe mostly consultants is my guess. Very small percentage of people from the ED floor, and 18% ICU. Okay, well that's good, because we'll be talking about an ICU topic, so I'm glad that we have some ICU people represented here. Okay, so I tried this earlier, which is why you see some responses here. So this poll is basically, again, you can sort of join the poll and then just put in what your favorite food is. You don't have to say who you are. It's not, just something fun. So go ahead, put something in. All right. Anything different? A lot of pizza. So the more people answer a specific food item, the bigger it looks on the screen. So let's see if something else could pop up. I think pizza's the winner here. Okay, great. Well, listen, thanks everyone for bearing with me. um, Again, we're doing this virtually, so just a way to keep everyone engaged and for me to get to know you guys, actually. So as Dr. Lau said, I have nothing to disclose. I will be talking about some medications that are not FDA approved for status epilepticus, but on the other hand, they're also commonly used and accepted treatments. So uh, not something that I think is particularly interesting or matters here from the standpoint of disclosures and conflicts of interest. So as we talk about the first part, so I'm going to do maybe 3 sections. You can think of the talk in 3 sections. The first is what I consider classical or convulsive status epilepticus. And while we talk about that section, I want you to think about this patient. I want you to have this patient in the back of your mind because she really is sort of representative of this type of status epilepticus. And then we're going to talk closer towards the end of the talk about what I consider non-convulsive or non-classical status epilepticus. And really, this is the kind of status epilepticus that's only recognized by EEG. It's the kind of status epilepticus that we've been focusing on more and more in ICUs in the last maybe 10, 15 years. And I have to say, 30, 40 years, it just wasn't something that was studied or looked at, but it's becoming a much bigger component of what we think of as status epilepticus today. So in giving a talk about status epilepticus, I really have to sort of focus on that also. And then the last part of the talk, which is a relatively small component, is just trying to show you how important the EEG is, both in the sort of classical convulsive status epilepticus, and also in this sort of newer sort of diagnosis of status epilepticus made just by EEG in ICUs typically. So, so case one, again, hold this case in your head as we talk about status epilepticus. Case one is a 24-year-old female who is really like amazingly healthy before this happens to her. There was a question of whether about 2 weeks before she presented, she had some kind of diarrheal viral illness. It was a 24-hour type of thing. There was no fever. She was a college grad. She was living with her fiance, and there were plans for marriage and essentially a full normal life. Then she essentially started having uncontrolled seizures, recurrent convulsive seizures at home. When this begins to happen, of course, you call 911, right? So if someone has a seizure, they've never had it before, you want to make sure there's not a medical emergency. In this case, it wasn't just a single seizure. She had repeated seizures, and they did not stop. So as you can imagine, she was quickly evaluated and intubated, and she was actually in the ICU for 2 months. The 2 months really just focused on treating the recurrent seizures. So she had prolonged and recurrent seizures. Over time, they became less convulsive, so she stopped showing that she was seizing, and they were more and more seen just on EEG. Finally, we were able to resolve the status epilepticus, and she was discharged to rehab. But she is now a new person. She has no memory, so because she's had such prolonged status epilepticus, she essentially damaged both her hippocampi, which are the memory areas of the brain. And she's really now unable to take care of herself. She can't get up and walk around normally. She's very weak, diffusely. She needs a wheelchair to really walk around the house. She's lost her fiance. She's now back living at home with her parents. She's living at home on 5 anti-seizure medications. And even with those medications on board, she's admitted to the hospital every few months because she still is having breakthrough seizures. So this is really the travesty. This is really the disaster that can occur with status epilepticus. And that's what we're going to talk a little bit about first today. So it's worth getting everyone on the same page with some basic definitions. So clearly status epilepticus is kind of a severe form of seizure, right? So it's worth thinking about what is a seizure. And so we have this relatively formal definition of a seizure. It's defined as a transient. Highlight the word transient there because that's pretty critical. Transient occurrence of signs and or symptoms due to abnormal, excessive, synchronous neuronal activity in the brain. So it's a brain problem, right? So a bunch of neurons get together, they misbehave. But what's really critical is that even the fact that you have a seizure is abnormal. Seizures end. It's a transient problem. And so a typical convulsive seizure lasts about a minute, minute and a half. So these mechanisms get activated, you have a seizure, but the brain also has natural mechanisms to end the seizure. On the other hand, what happens with status epilepticus is that the seizures don't stop. So, and of course, in the history of neurology, we've been dealing with this for a long time. It's been recognized for a long time. In 1867, Trousseau, a very famous neurologist and neuroscientist, said, in the status epilepticus, when the convulsive condition is almost continuous, something special takes place which requires an explanation. So it's not just a typical seizure, something different is happening. And more recently, in 2015 or so, it was worth it to go back and look at status epilepticus and come up with some basic definitions. And conceptually, this modern definition includes a recognition that there's been a failure of mechanisms that end seizures. And so basically after a certain time, called time 1, that's when this failure has occurred. And ultimately, of course, what we worry about is my patient Jenny, right, the one I discussed a couple slides ago, that she'll have long-term consequences. And so after a certain time, we realize that there will be long-term consequences of the status epilepticus. So at this point, we consider this first time where there's failure of termination of a seizure as time equal 5 minutes. Essentially, T1 is 5 minutes. And that's for typical convulsive motor status epilepticus, like what my patient Jenny had. And time 2 is thought to be somewhere about 30 minutes. I have to say that there's still some research that's a little bit unclear about when this time 2 occurs, and it may vary dramatically depending on the type of seizure, the type of status we're dealing with. I want to say with the idea of time 1 being 5 minutes, this basically comes about because we know that typical motor seizures last a minute and a half. And so if for most things in science, we think about 2 standard deviations above and below as sort of the cutoff for abnormal. So that's where that time 5 minutes came about. It's basically 2 standard deviations above what a typical seizure would do. And so we know at that point something wrong is going on, something that is really special, as Trousseau alluded to in 1867. So it's worth looking at some other definitions. So once you have hit that 5 minute mark, so you either have one convulsive seizure lasting longer than 5 minutes, and you're now essentially in status epilepticus, or you could have 2 or more seizures back to back where you have not returned to baseline in between. So at this point, you're in status epilepticus. It's also worth discussing what refractory status epilepticus is, because I want everyone to be aware of that by the time most patients who present with status epilepticus, by the time you're seeing them in the ED or even in the ICU, they're probably in refractory status epilepticus. So this is one of the sort of key points I wanted to make. So the seizures have continued after first and second line treatment. That's kind of a practical definition that we're using today, because typically most seizures, if you give them the first line of treatment, they'll stop. And so if the seizures have continued beyond that first and then the second treatment, that's basically refractory status epilepticus. There's also an older definition that can be used where essentially the seizures continue beyond 60 minutes. Of course, we have super refractory status epilepticus, which is where medications, including anesthetic infusions, have not worked, and especially if this has been ongoing for equal to or greater than 24 hours. This super refractory status epilepticus also includes patients who we think the status has resolved. We have them on anesthetics, and then we stop or wean the anesthetic, and the seizures recur again. So demonstrating that it really has not been fully controlled. So what are we talking about here? How important, how prevalent is this problem? Well, clearly it's not super common, right? So we have in the United States, including both children and adults, somewhere between 150 and 200,000 presentations of status epilepticus per year. There's an older population level study that talked about an incidence of 41 per 100,000. I think most people believe the lower number, which is the incidence of 18 per 100,000, and this is in line with other studies from other parts of the world, such as in Europe. So we have a relatively rare condition. Think about this, right? So 200,000 people, that includes children and adults in the United States in a year, right? So however, we have mortality rates that can be as high as 30%. We know that in children, the mortality is a little bit lower. So we have numbers somewhere between 3 and 7% of people die from status epilepticus. But somewhere between 20 to 30% of adults will die from status epilepticus. So we have a relatively rare condition. However, we have a condition that there's a relatively high mortality. So I also want to stress that, sort of treating early is pretty important. So I'm going to jump to the last point here that talks here about the Rampart trial. This was actually a trial. It was pre-hospital treatment of status epilepticus, and this was comparing IV lorazepam to IM midazolam. And that's not the real point here. The real point here is that in that clinical trial, between 60 and 70% of people, their status was aborted before they arrived in the emergency room. So these are patients, the EMS arrived at the scene, they established that the patient's still seizing, they've been seizing for 5 minutes or more, they give them IV lorazepam or IM midazolam, and basically most of them, by the time they got to the ER, status was resolved. So really showing that if we can get to it very quickly, that maybe at least 70% of people can be treated effectively. So those people that don't get treated early, or potentially they have a very severe disorder that doesn't respond to that initial treatment, of course, 20 to almost 50% will progress to refractory status, and then we have about 22% of patients with refractory will progress to super refractory status epilepticus. Again, so holding, my patient Jenny in your head, I mean, she was clearly the most refractory of the refractory cases. So etiology, well, it's a bunch of different things, right? So a lot of different things can cause status epilepticus. Typically, when you present with status epilepticus, you don't have a history of epilepsy. So most people who present in status epilepticus don't have epilepsy. However, at the end of status epilepticus, probably somewhere close to 50% of people will have epilepsy afterwards. So there's a couple different ways to think about etiology. The International League Against Epilepsy just sort of characterized etiology for epilepsy in this sort of structural, metabolic, inflammatory, infectious, toxic paradigm. And you can certainly think of it that way. Other people think of it in terms of whether there's an acute process going on, such as acute meningitis or encephalitis, or whether there's a prior brain issue that essentially has caused the status epilepticus. If you have a progressive condition like a neurodegenerative problem or a brain tumor, that is another possible sort of reason for status. And there are some specific, usually metabolic or genetic epilepsy syndromes that do have a high chance of presenting in status epilepticus, such as Dravet syndrome, or there's this absence status in ring chromosome 20 syndrome. And then there are the people that we never figure out what the cause of status epilepticus is. So for simplicity, we're now using very simple words. We're trying very hard in neurology. So we can certainly say cryptogenic, but unknown is acceptable. And I do want to, so we just don't figure out very quickly, very easily, why that person went into status. There are two disorders that have been recently defined, Norse and Fires, that basically we probably should talk about. Before I get to that, so one thing that is important to note is that the etiology of status does vary a little bit with age. So in children, there seems to be a high rate of fever infection that is essentially explains the status epilepticus, whereas in adults tends to be more likely to be vascular disease or tumor, etc. So there are these rare refractory status epilepticus cases, and there's two sort of paradigms that have been used. This Norse syndrome, so new onset refractory status epilepticus. And you may also have heard, some of you may have heard about FIRES, which is febrile infection-related epilepsy syndrome. And these are basically people that present with refractory status epilepticus. FIRES was first described in younger people and children. However, because there was a lot of different terminology being used, a bunch of experts from basically from the United States and from Europe got together recently in 2018 and decided to just at least have some basic consensus definitions. So these are expert consensus definitions. And so this Norse is basically a clinical presentation. It's not meant to be a diagnosis. Couple important things. It's absence of preceding epilepsy or baseline neurological disorder that could predict abnormalities. You have to present with refractory status epilepticus with no obvious acute toxic structural metabolic cause. However, once you've investigated, at least a subset of these patients have an autoimmune cause, and that's you're still allowed to essentially call it Norse if there is an autoimmune cause identified. And if there's no cause identified, the presumption is that it may be autoimmune, but it's something that we haven't found yet. We don't have the antibodies yet. So FIRES had been described in the literature as mostly a childhood-related problem. However, at this point, it was felt that there was no reason to expect or that it would only be limited to children. And so it's now put under the category of Norse, and any age can be included in FIRES. The important differentiation or the important issue or the important thing that defines it as opposed to regular Norse is that there's a febrile infection within 2 weeks, somewhere between 2 weeks and up to 24 hours before the refractory status epilepticus. And you don't have to have fever at the time of initiation of status epilepticus. So these are just some basic definitions, just so when we talk about these conditions, when we report these conditions, when there's research being done in these conditions, that we're all speaking the same language, and so we can make some progress in trying to understand what the etiologies are. So I want to touch on a little bit of the physiology, and I don't want to get too heavy into this, but I think it's important because to think about the physiology, because there's a lot of what we do in status epilepticus that we don't have, really clear science for. So trying to, or at least clear clinical trials with regards to treatment. So trying to, when we understand the physiology a little bit, and I think we can make some educated judgments as to what we need to do for particular patients that we're treating. So, so think about the status epilepticus as essentially sort of a failure of inhibition. So a typical seizure, right, begins, but there's clearly a process for inhibiting and stopping the seizure. With status epilepticus, that's failed. So this process, these inhibitory processes are usually mediated by a neurotransmitter called GABA. And another clearly possible explanation is that we have too much excitation, too much revving up the system, right? So, and these excitatory mechanisms are usually mediated by a neurotransmitter called NMDA. Of course, it's probably both, depending on the situation, and usually our medications target GABA and or NMDA. So, just broadly, when we think about the physiology. With regards to convulsive status epilepticus, what we're talking about today, with my patient Jenny in mind, remember, really, there's been a fair amount of research. This research has included sort of really clear in vitro studies, but also in vivo studies, even in non-human primates. So we've got sort of a rich amount of data, and this data essentially has been collected over the past 60, 70 years. So there's these two main methods of creating models for status epilepticus from which we can study and understand what's going on. One of them is a chemical method where we use essentially drugs to trigger status epilepticus and then study it. And then there are electrogenic methods where essentially we put an electrode in parts of the brain that we know can create seizures and cause status epilepticus. So those are the main categories of research that's been done in terms of understanding what happens in status. We also know that something goes kind of crazy in status, right? So the brain's going crazy, there's all these seizures going on, and instead of GABA, right? Remember, that's the inhibitory receptor. Instead of GABA essentially coming to help us to inhibit the seizures, these GABA receptors, which are supposed to be inhibiting seizures, they essentially get sucked inside the cell. They get moved away from where they should be working really hard. And so this is definitely a problem. So we're depending on GABA to come in and essentially stop the seizures. And it doesn't. In fact, it almost runs away from the action, so to speak. And the other thing is that these excitatory receptors here on the bottom of my screen, the NMDA receptors, they increase in number. So there's some kind of failure of mechanisms that should be occurring in status epilepticus. There's a lot of other work that's ongoing in the basic science level here, but I think this still encapsulates sort of primarily what we know about what's going on in status epilepticus. Now, I love this graph. It's kind of from an old study. And interestingly, I've been using this graph since I was a resident. So it hasn't really, essentially, it's still very applicable today. So on your x-axis here, you have time. And so here is where status begins. And then here is this transition phase, right, which we know after this point, there's probably going to be some neurological damage. And then somewhere about 60 minutes, again, these times are relatively, they're not sort of set in stone. Essentially everything goes haywire and you've essentially lost control of this process of status. Now, along the y-axis, there are lots of different parameters that are being measured. So first is brain lactate, the brain energy state, brain glucose, brain oxygenation, brain damage. See this line here with brain damage? See this brain damage, nothing's occurring. And then as we go past this transition phase, then we begin to see brain damage after that. And then there are some systemic factors that we can look at. So blood pressure, glucose, etc. Initially, blood pressure is elevated in that first phase before that transition phase. And then you'll see that in that after the transition phase, blood pressure begins to drop. So there's beginning to be a failure of mechanisms here that sort of represents status progressing and becoming a problem that it's going to be harder and harder to intervene on. The last two graphs talk about EEG and what's happening with the patient clinically, what's happening with the shaking, the convulsions that we see in these seizures. And this is also, I think, very instructive, because in the first phase, the patient's having convulsive seizures that you can see. And then somewhere along the line, there's a transition where the patient no longer has obvious tonic-clonic or convulsive seizures, but they may have more subtle findings like myoclonus or jerking, or maybe eyelid twitching. And then ultimately, at the end, towards the end here, so really long past where we're able to, we can't really see the patient clinically sees anymore, we see that there may still be EEG seizures or certainly EEG abnormal activity, but nothing's happening clinically with the patient. So this model is really been sort of looked at for a number of years, many different models, looked at in baboons and other kinds of animals, and basically shows what we talked about earlier, where there's something that happens in the first phase, and you get to a place where it becomes harder and harder for the brain to compensate, for the brain, for lots of different things actually to compensate. And so you begin to see failure of these mechanisms, brain damage, decreased respiration, low blood pressure, et cetera, et cetera. So this, of course, summarizes lots and lots of research, and so, but it's still very important to think about it this way, especially in convulsive status epilepticus. And of course, it's from all this work that we have this general idea that there's status, and then established status epilepticus, and then subtle or refractory status epilepticus. So this slide is really meant to show that this is kind of research that underpins what we understand is happening in status epilepticus. And we have lots of different mechanisms here that may initially begin the process of status epilepticus. Here, there's research that shows what can block the initiation phase of status epilepticus. And I want to point out here, sodium channel blockers. These are drugs that we use very often in epilepsy for seizures. GABA agonists, right? So this is the inhibitor neurotransmitter. And the other main point of this is to show that once we get to sort of the end of status, where status is really sort of going on and on for a long time, there are fewer things that we understand about status. So, and here I want to point out that we have NMDA antagonists. So we do have some medications we use that are NMDA antagonists. So these are, essentially blocking the excitatory pathways to stop status epilepticus. So bear with me, I have a point with this. I want to show that we really should be thinking about some of these NMDA receptors earlier, probably when we treat status epilepticus. Okay, so let's talk about treatment for status epilepticus at this point. Again, hold my patient in your head, right? Remember, she was very healthy, she was very young, and came in and was in refractory status, was in the ICU for 2 months. So this is what we know. This is the evidence that we have for treatment of status epilepticus. We know we've got to act early, and so this is generally what we do in the first 5 minutes. We stabilize the patient and make sure, we do as much of a neuro exam as we can. We get history. We check glucose. We might get labs if we're lucky, if we're not, out in the field. And then we've hit that 5-minute mark, and now we want to use a benzodiazepine. Benzodiazepines are thought to be the first line of attack in status epilepticus. And this is basically from 3 large studies, which I've sort of highlighted here. The first is a 1998 VA study that looked at 5 different things to use first line for status epilepticus. And essentially you can say that lorazepam won the day. The other 2 studies, the Aldred study and the Rampart study, are pre-hospital treatment for status epilepticus trials, right? So these are trials focused on EMS treating status in the field. And both of those studies looked at certain types of benzodiazepines. The bottom line is that use benzodiazepines first, we can get them in quickly, and they can stop the process if we get them in early. Now, the next thing is when those benzodiazepines don't work, right? So remember the patients in the Rampart trial, either arm, 60-70% of them, by the time they got to the ED, status was resolved. But of course, in many people, status is not resolved. And in some people, the status recurs, right? So it recurs in the hospital. And so we typically go from using benzodiazepine directly to using a drug, a regular seizure medication, usually intravenously. And there's been several smaller trials and several observational studies, but one large randomized clinical trial that has essentially looked at phenytoin. Everyone in the United States, it's still a popular choice. So phenytoin at 20 milligrams per kilogram, actually it's fosphenytoin, compared to levetiracetam. I wanted to point out here that the doses used for levetiracetam in a clinical trial, 60 milligrams per kilogram. And I really want to point this out because for a 70 kilogram man, this is 4.5 grams of Keppra, guys. So whenever people use this, almost invariably, every time I speak to someone in the ED, they're underdosing typically. And then Depakote, valproic acid, was used at 40 milligrams per kilogram in the ESET trial. And what's important to know in this large clinical trial that was done essentially in Europe and the United States, lots of different sites, is that they're equivalent. Let me just say that again, they're equivalent. So you can use any of these drugs. I mean, phenytoin had a little bit more hypotension, but it was not clinically significant. So these are all medications that can be used for second-line treatment. So benzos followed by one of these medications. And in fact, many people in Europe are surprised that we in the United States still use phenytoin because they've been using Keppra and valproate for so long. The other thing to know about these medications, the Keppra and the valproate, is that they can really be infused very quickly. So you can get a full load of Keppra in 10-15 minutes, and the same with valproate. Fosphenytoin, probably not so much. So that's another reason to think about those other treatments that maybe are less popular in the United States. Okay, so now you've used your benzo and you've used your probably levetiracetam at a good solid dose, right? Maybe at least 4.5 grams infusion, and the patient's still seizing. So, well, at this point, what I say is that you're now a cowboy and you got your guns blazing and you can do whatever you want, because we don't have a lot of great large-scale clinical trials to inform what we do here. We do think, so this is general practice, that at this point we need to put the patient in coma. We put the patient out. So sedative anesthetics, and then we try any number of anesthetics to help essentially stop the status epilepticus. And I'll talk a little bit more about that. So just to highlight this, the large clinical trial called the ESET trial that was published in the New England Journal, looking at the three treatments for established status epilepticus, right? So this was almost 400 patients were randomized to one of these medications. And, like I said, really what important to note here is the outcome was absence of clinically evident seizures and improved responsiveness at 60 minutes. This clinical trial, because it was being done across many sites across the world, did not use EEG. They were not sure they could get EEG done in every single institution. So basically using essentially just the patient waking up within 60 minutes as the outcome. And they essentially are equivalent, right? So I also want to highlight this meta-analysis. So almost right after the ESET clinical trial was published in the New England Journal, there was a meta-analysis that put together data from over 1,100 episodes of status epilepticus. And so you can imagine in a meta-analysis, there are, of course, randomized clinical trials, but there are several observational studies that were included. I think there were 2 trials looking at phenobarbital and 2 of them looking at lacosamide. So what I want you guys to really pay attention to here is that, phenobarbital, that old drug that nobody likes to use, actually performed the best in this meta-analysis. So phenobarbital is right up there, beyond 75% in terms of its response to eradicating status epilepticus. So I just want to point that out. So I think we can sometimes, we can certainly use phenobarbital and not feel bad about using it. And then the other drug that I want to point out here is lacosamide. So we don't have yet any large randomized clinical trials. So lacosamide, Vimpat, is another medication that's very popular, popular because it's so easy to use. It's available intravenously. And so obviously we can probably consider using it in status epilepticus, but we don't have large clinical trials as yet. But in this meta-analysis that included some observational studies, lacosamide, I would say, performed quite well. So my question here is, where is phenytoin here? Phenytoin's failing, when you compare to the other drugs here. So another, just to put that in your mind, maybe we can use other medications that are easier to use and are just as effective for status epilepticus as phenytoin. Okay. All right, so now we're on to, the patients now with refractory status epilepticus, right? And they have not responded to levetiracetam, and so we're now putting the patient in the ICU. They're in coma, and we're using, usually in the United States, one of these three medications, midazolam, propofol, and pentobarbital, as a continuous infusion to suppress seizures. Here are some standard sort of loading doses, etc., on this slide. What I wanted to sort of highlight here is that we have ketamine, which is when centers are surveyed, it tends to be the medication that's tried last when everyone's really desperate, but it is an NMDA antagonist, so it can suppress that excitatory pathway. And so it's something that we might want to consider sooner, because we generally use midazolam, propofol, pentobarbital, and then when we've sort of run out of options, then we consider ketamine. And as I showed you earlier, the NMDA mechanism might be pretty important in refractory status epilepticus. So thinking about ketamine earlier might be something we can do. Again, we don't have large sort of comparative clinical trials, but as we're thinking about this, we sort of fall back on the science, and something that I think we should probably consider. Actually, I've been surprised that since I've been here that we used ketamine quite a bit in this institution. So perhaps some of the forward thinking of the intensivists that are here. All right, so you've heard some of this. So we don't have large clinical trials. For the people that are really, really refractory, we use barbiturates and propofol and midazolam, essentially most. Like I said, ketamine should probably be considered earlier. Don't forget our good old phenobarbital. I think we really, that drug, I think we give it a bad rap, and it may perform much better than we usually think about. So we probably, in those cases that are similar to my patient, we probably do want to think about immunotherapy. Is this NORSE that's with an unexplained autoimmune process? Possibly. There are some other people that are trying things like ketogenic diet, even VNS and other types of things. So this is really where we're looking to see if there's anything that will lead us in a direction that will find a specific treatment at this point. So here is an audit that was done. This was a study, this is primarily done in Europe, but this was an audit of 776 cases of refractory status epilepticus. This came from about 50 different countries. And here in green are basically the people that had good outcomes. So, so this sort of green here, and it's sort of broken down by different etiologies. So the highest numbers are green, right? So these are people that presumably have epilepsy because there was anti-epileptic drug withdrawal, and also genetic. So I'm presuming that, so this basically the summary of this is that the outcomes seem to be best in people that have epilepsy, right? So outcomes from essentially recovering from status epilepticus. But other people really in other types of etiologies, the outcomes are much not great at all. Anoxic, for instance, is one of the lowest good outcomes in the group, this group of etiologies on this in this study. So we're going to switch over to our other type of status. So here are some general principles. Practically, what do we do? We always give a benzodiazepine first. At this point, it doesn't matter what route. If you can get some benzodiazepines in, then do it as soon as possible. Then we start with our non-sedating anti-seizure medications. If we have to go to, if we don't respond at that point, we're really putting the patient on a continuous IV infusion. That's been the practice. And at this point, we would recommend continuous EEG, or at least very frequent EEG, to help us understand what the goals of care at this point, and to really see what's happening with the patient, because we would have lost an exam at this point. So this is a great chance when the patient is essentially comatose to really go back and look at what's the etiology. Is there a more specific treatment that we should be considering? Typically, we have the patient in coma for up to 2 days or so, and then we attempt to wean the anti-seizure medication, and we can repeat as needed. So, all right, so now we're going to switch gears, and I'm calling this not classical or spontaneous non-convulsive status epilepticus. And again, just like how we had our patient in our head when we talked about the classical type of status epilepticus, I want to So I want to sort of describe a case that is more typical of the kind of patient that we will see with this kind of status epilepticus. So this is an older guy. He's a previous brain problem, so he had a right MCA territory stroke a few years ago, and then he fell and came in with a traumatic left subdural hematoma. And so he went straight to the operating room because it was a pretty big subdural, and they essentially decompressed him. Surgically, he did great. No unexpected issues at surgery, but he's now in the ICU, and 24 hours later, he's not waking up. He's got some bump in his creatinine. We did, of course, do a CT scan to make sure he's not rebled, and that looks pretty good. EEG now shows electrographic status epilepticus. So he's not clinically shaking, so not convulsive status epilepticus, but EEG suggests he's having a continued seizure. So what do we do with people like this? What do you guys think about patients like this? They're already compromised, they're in the ICU, they don't have any clinical signs of status, but the EEG shows that they're in status epilepticus. You guys ready to do another poll? So, so if you still have your poll everywhere up, what do you want to do for this guy? So he's in status epilepticus as defined by EEG criteria.
Houston Methodist is open and safely caring for patients both in person and virtually. Your health and well-being are our top priority, now more than ever as we work to...
Okay. Do you want to crank up the sedative anesthetic until the seizures stop on EEG? What do you think of that strategy? Or do you want to start an IV anti-seizure medication? Ignore the EEG, just put him on a medication. Do you want to start benzodiazepines at high doses and then assess the EEG afterwards? Do you want to do benzo, then anti-seizure medication and assess EEG? Or do you want to do nothing? All right, everybody should take a stab at this, even people who are not clinicians. So remember, this is a guy, he fell, he's got a bleed in the brain. They took him to surgery, they removed all the blood, but he's just not waking up. He's in the ICU, and the EEG shows he's essentially in status epilepticus. Oh, wait, like 30 more seconds. We have 5 responses. Where are those neurologists? 6 responses. Where are those ICU guys?
Some people are asking how to get on the poll. So if you don't have the poll already enabled, you can just go ahead and put your answer in the chat box.
Yeah, that would work too. That's awesome. Yeah, the poll, it took a little bit of time to get the poll going. You had to text 22333 and then put in that Omotola Hope 264 code there, and then that sent you a link. I think we'll move on in the interest of time, though. Thanks, everybody. Let's see what we got on the poll itself. So we got some neurologists probably who said start benzo and anti-seizure medication and assess the EEG. Nobody said do nothing, and then a little smattering of everything else. So I like crank up the sedative until the seizure stop. So it's probably one person. That's good. Okay. So, well, here's the thing about this kind of status epilepticus. We don't have a lot of data. There is no animal model. There is no experimental status epilepticus like this from which we can infer what to do. And so we're really left kind of thinking about these cases in a special way. So I go back to the definitions because clearly something is going on that's different, right? This is not a transient, this is not a seizure, right? This is a continuous process. The patient's continually seizing. So clearly there's status epilepticus. And when is this time one? When do we decide that there's some kind of failure of normal mechanisms? Well, we don't really know, but we presume that at some point, right, we have to kind of call a time. And we've sort of gone with the International League Against Epilepsy rule of saying 10 minutes of continued seizures on the EEG status epilepticus. What's time 2? Another one that's really unclear, and we don't have a lot of basic research to help us define this number. Clearly, we don't want it to go on too long, but I don't think we quite know what time 2 is where we would expect neurological problems, after the seizures ongoing for that long. So you know, that we do have some definitions, and actually there's been a lot of developments in the last 10 to 15 years and just trying to name things correctly so that we're all on the same page. So the EEG criteria for status has been defined by this guy called Salzberg, and it's been worked on over time and it's been fine-tuned. So now electrographic status epilepticus is considered essentially a continuous seizure for more than 10 minutes. And in people who are essentially you know, they're on continuous EEG monitoring and they're just seizing all the time, we also have another criteria where it's more than 20% of a 60-minute period of recording. So, and we see this data, this 20% now comes from mostly the neonatal literature that suggests that more than 20% of an hour of continuous seizure seems to increase the chances of having cognitive and other problems. So those are the formal definitions of electrographic status epilepticus. So using the EEG to define what status is. And, you know, there's still a lot of disagreement in the approach to treating these people. So on our left, the people that agree or want to do a more of aggressive approach would say that, well, we know that in some populations when there is status epilepticus in these ICU patients, that there's more blood forming, there's hematoma expansion, and so maybe we should be more aggressive. And in people with status epilepticus explained by brain hypoxia, we know that there's increased intracranial pressure, so that's not good, right? We know that if we have status epilepticus, there's poor cognitive outcomes and epilepsy, so maybe we should be aggressive. And then there's other people that say, well, the prognosis is really not defined so much by the status. It's defined by the fact that this guy had a subdural on top of a right MCA stroke, plus his age and his renal function and so on. So does being aggressive with the treatment actually help, especially when we know that aggressive treatment promotes longer ICU stays, more infections, and increased morbidity from the ICU stay. So it's really unclear that there's overall that, you know, what we should do, although I would say that the general approach is that in patients like this, we should be gentler and we should use the EEG to help us understand what's happening with the patient, because we really don't have an exam. So what experts in this field recommend is that we should try with a benzodiazepine. Again, looking at the EEG, because that's how we're measuring the patient's progress. So maybe lower doses than you would use in convulsive status epilepticus. And then you do start an anti-seizure medication, one that can be used intravenously. Again, you're using the EEG here to help you, right? So if your EEG shows improvement after, you know, 15 milligrams per kilogram of phosphatidylcholine, then maybe, you know, you need to just adjust the dose and leave it there, as opposed to going straight from phosphatidylcholine to an anesthetic. So that's the general approach at this point. Again, I think there are arguments for a more aggressive approach, but I think overall we feel that the ICU complications from the aggressive approach in these types of patients maybe overrides the benefit from being aggressive on the status epilepticus. So to summarize what we know about this kind of status, we need EEG to make the diagnosis, and we've increasingly been seeing that in ICU patients, somewhere between 8, sometimes as much as 20% of ICU patients who are obtunded have been seen to have subclinical seizures and status. So EEG seems to be more and more important in these types of patients to understand what's happening with them, why they're not waking up. We do need EEG for continued treatment, right? We need to sort of have the EEG improve, because that's really what we're using here as a measure. You can treat with lower doses of benzodiazepines and regular anti-seizure medications. And generally, you know, you optimize one medication, then you add a second medication as needed. And of course, paying really close attention to all the other things that's going on in the ICU so that you limit the ICU stay as much as possible. All right, so this is where we switch a little bit to the EEG stuff. And I want to sort of underscore that when we do EEG monitoring, it's really a team approach, and it's so important that we talk to each other. You've got an intensivist, you've got nurse, you got in our institution here, we have a neurology consultant who's not necessarily the intensivist. We have an EEGer, so that's usually me or one of my colleagues, and an EEG technician sort of working together to help with the EEG. And you know, the other thing is that, you know, when we do these EEG reports, they're really meant almost for sort of documenting a 24-hour period of monitoring. We don't often sort of give blow-by-blow assessments of what's happening with the patient. So I think that these patients that are being treated really need a daily discussion, almost like rounds, so we can fill in the gaps and figure out what needs to be done with these patients. The other thing with EEG is that there's a lot of things that are not so clear. So we talk about burst suppression all the time, right? So you have this patient in coma because you're treating status and you want to get to burst suppression, and nobody knows what burst suppression is. And so here's a patient who's got a burst, and then there's a little bit of attenuation. This is actually not suppression because we can still see some activity. So burst attenuation, but here's a patient who's got burst suppression, right? And when we talk about the burst suppression, we talk about how much time they're spent in suppression and how much time that they spend in bursts. And I think what's coming out more recently is that what's really more important, more than the actual burst suppression, is that when we see the burst, that they do not look like this. They do not look like epileptiform activity. If the bursts begin to look more slow, then we're somehow making headway and we can attempt to wean. But if the bursts look epileptiform like this, then this predicts that the patient is going to be unlikely to be weaned successfully. So maybe we shouldn't try, and we should try other treatments before we wean the patient. So these are just some of the things that can be complicated with EEG interpretation and what's happening with the patients in these cases. Here's a burst suppression pattern that maybe is a little bit more predictive of success when you wean the patient. The other thing is periodic patterns. So here's an EEG pattern that could just be somebody in coma, not necessarily a seizure. But if I can see that with every one of these discharges on EEG, there's actually a twitch, something clinical that I can see, then this patient is now in convulsive status epilepticus. And of course, we talked about how bad convulsive status epilepticus can be and how aggressive we likely need to be to treat it. So sometimes the patterns themselves can be difficult. We really need people to be talking to each other, the persons at bedside, the nurse, the EEG tech, to really understand, oh, that's a twitch, and we can coordinate the twitch with what's happening on EEG. Now we have a convulsive status epilepticus state. Okay, the last thing that's a little complicated with EEG is that there's a lot of patterns that are now being called ictal interictal continuum. And so again, discussion is often helpful, right? So this is somebody who, by that EEG Salzburg criteria, is not having status epilepticus, but clearly these discharges are so frequent that potentially they're affecting, they're having some kind of neuronal injury in the brain. So EEG monitoring is critical, is really, really important. So we need it both for classical status epilepticus and for what I'm calling the non-classical or spontaneous ICU EEG status epilepticus, so really critical both. Remember, this epileptiform burst with the burst suppression is really not good for weaning patients off anesthetics. And when we have these sort of spontaneous status epilepticus, subclinical status epilepticus, we want to look at trends as opposed to like complete resolution of seizures often. We want to look at improvement over time. So, all right, so one controversial thing, and then I'll let everyone go. So sometimes I'm asked, do we need continuous EEG? And I would say this clinical trial tried to address that question. Continuous EEG, this is a randomized clinical trial. It was not done in the United States. It was done in Switzerland versus repeated routine EEGs. Nobody in the US is happy with the clinical trial. All the experts think there's lots of issues with it, so I won't sort of belabel that. But just the idea that looking to see whether we do need continuous EEG and whether we can replace it with repeated routine EEGs. The bottom line is that mortality is the same, right? So mortality is the same. Here are the results. With continuous EEG, of course, we saw more seizure detection and we saw more medication changes because we detected seizures. And so we're not sure what that means exactly. But I want to press you, basically show you that, look, if you have a different way of doing things, certainly there are other people that are thinking about this in the same way. And in hospitals that don't have the resources, they can probably still take good care of patients in status. They just have to be really, really careful and really have closer communication, even closer than what we have when the patient's on continuous monitoring. So that's relatively controversial. So overall, beware of types of status. This ICU EEG only status is sort of the new guide, the new diagnosis. We really need EEG to make that diagnosis, really work together as a team. With refractory generalized status epilepticus, the ones where people convulse, we really want to be aggressive as soon as possible. We really want to try and eradicate the seizures as soon as possible. We want to try and understand the etiology. And again, the team approach is really, really, really critical. So before I stop, I have two special clinic populations I'm trying to capture. These are first seizure patients, and then are people that are sick in the hospital with seizures who need to be seen in the clinic afterwards. So it's being called the PASS clinic. So remember, I'm here and you can send those patients through. And I'm happy to take questions, and there's your CME information for people who still need the information. Thanks for your attention, everyone.
Thank you, Dr. Hope. That was really wonderful. If people do have questions, you can go ahead and ask them now. I see some comments coming up in the chat box. Excellent presentation. I had another comment that it was the best status epilepticus lecture ever. So congratulations, Dr. Hope. That's quite a high bar. But if anyone does have questions and you don't have time to answer it now, certainly you can forward them to Dr. Hope. She has a Houston Methodist email, and we would be happy to facilitate getting those questions to her too if you need to. If you are a physical therapist, physical therapy assistant, please fill out the evaluations. I can send it to you directly, or you can get it from your director. Otherwise, if you're CME, like Dr. Hope said, just call that number and put in the event code and you'll get your credit that way. And I do have completion certificates for everybody else. It's not official CME or continuing education, but you may be able to use it, for other purposes. So I'll send that out to all the other participants.
Thanks, everyone.